Welcome to Help in a Crisis, Suicide Prevention in the Upper Valley Lake Sunapee region. I'm Bridgett Taylor of Communities United Regional Network for Sullivan County, and I'd like to welcome my guests, Suellen Griffin and Fred Hesch of West Central Behavioral Health. We're here to talk about mental illness, suicide, and finding help and hope for people in crisis. Suellen Griffin is President and CEO of West Central Behavioral Health, a community mental health center which serves Lower Grafton and Sullivan counties. She is a psychiatric nurse practitioner and has over 30 years of behavioral health experience. Suellen holds a master's degree in adult psychiatric mental health nursing from Yale University and a bachelor's of business administration from Pace University. She is a fellow of the American College of Healthcare Executives. Fred Hesch is the Director of Emergency Services for West Central Behavioral Health. Fred has a master's degree in clinical psychology from Central Missouri State University and has been a staff member at West Central since 1975. West Central's Emergency Services Program provides 24-hour mental health crisis intervention at 1-800-564-2578. It is available to all residents of Sullivan and Southern Grafton counties 7 days a week. Thank you both for being here.
Thank you, Bridget.
So I think one of the things that people first start with when they're trying to understand suicide and mental illness is how people get to that point. How does mental illness start? And I know the answers aren't always clear, but if you guys could talk a little bit about how mental illness affects people and where it sort of comes from.
Sure. Mental illness is often hereditary. It's passed down from generation to generation, and that's specific diagnoses, not all diagnoses, but that's often. Unfortunately, people can't do a whole lot about it when it is hereditary, but that is one way that, that people do become mentally ill. And the other is really environmental factors. People will have life stressors, currently losing jobs, difficult economies, relationship issues. You know, for adolescents, we look at school issues, peers, and what really is classified as a mental illness is really the person's ability to function at the highest level that they can function. And so that's really our measure, is saying that people want to do well, they want to have jobs, they want to do well in school, and when their ability to cope and to interact in society is stressed, then that's when we intervene, and we try to bring people to a level of their best functioning.
And of course, the sort of other end of that, where you're at your perhaps least functioning, is when you have a person who is suicidal. And what are some of the things that is a risk that a person will become suicidal?
Well, there's lots of factors. Often when you think about suicide, it's goes hand in glove kind of with people who are depressed. So one of the things about understanding suicide is also understanding depression. And when you think about depression, again, you think about the stressors of one's life, perceived losses, real losses that people have gone through, changes with their life, their coping skill, their health. Any number of impacts can affect people's moods in a depressed way. So often it's focusing on depression. Other factors with suicide are substance use and substance abuse issues. That's kind of a major impact on people's ability to function and make good decisions. And then there are also kind of crisis suicides, where people get into kind of acute states, something that happens very quickly or immediately that just overwhelms their coping skills completely, so that they're at a point where they're not able to use their wisdom and their judgment to make good decisions about options.
So that would be something, instead of an extended period of depression, it might be a car accident, a loss of a loved one, where you end up in that crisis situation.
Yeah, very much the case of that. People losing their jobs, kind of an acute situation that they're unexpected, didn't plan for, and just become so overwhelming that their typical coping skills aren't effective.
And if I might add just a couple of other small points about the risk of suicide. If somebody has made a prior suicide attempt, that does increase the risk. If someone talks about suicidal thinking, not that we don't take it all seriously, but that is a risk factor. In addition, believe it or not, suicide is often hereditary as well.
So just makes a certain amount of sense.
Just as another point of reference, and we do ask those questions when we're talking to people. Has anybody in your family ever, attempted suicide or completed suicide? So that does increase the risk of someone else or someone in the family.
Yeah, and of course there are probably some people who don't know. you know,
Yeah,
so-and-so died in a car accident, we always wondered.
yeah, absolutely.
I'm glad you brought up substance abuse because I had it on my talking points, that alcohol and drug abuse disorders are actually associated with a 6-fold increase in the risk of suicide attempts. As we've talked about before, as Communities United, substance abuse and mental illness often go hand in hand. That's one of the reasons Suellen has been a leader in our organization.
Mm-hmm.
And I think I want to get a little bit into the emergency services line, what it's really about, what happens when someone makes a call.
During both during the day and after hours, the 800 line is answered by a staff member in the answering service. The information is immediately paged to one of the professional emergency services staff. There are 4 people who are on my staff who cover the line. And that after receiving a call, we immediately call back, assess the situation, try to find out, again, as much as we can about what the current crisis is about, trying to assess the occurred stressors, things that maybe were leading up to that, getting to know the person in the situation as much as possible, and then start working on trying to do an intervention over the phone about how to relieve some of the stress. And also, in the back of our mind, always thinking about the dispositions of the next step and what the plans are, trying to come up with positive options about where to go from here.
So there's always a human being picking up that phone. There's never a busy signal or an answering service.
Yeah.
Well, there's
an answering service.
But it's a human answering service.
Yes.
And what kind of training do people who work the line go through?
My staff is a very experienced staff. I think they all have 30-plus years in working in the system. And also being on emergency services staff for a number of times. There's lots of trainings and in-service, as well as, again, our experience in the mental health field.
What kind of changes have you seen over the years? You've been doing this since 1975. That's 37 years.
Oh my goodness, there have been a lot of them. Probably one of the biggest ones have been things like so much research is being done and continuing to be done as far as effective treatments and best practices and evidence-based practices, so that outcome studies for a lot of research are then being able to be implemented in kind of specific plans and specific therapies that we know work.
Do you sometimes wish you could go back in time?
Oh, very much so.
So why do people call? Are most of your calls people who are very close to an attempt? Is there a pattern? Do people just call when they're feeling overwhelmed?
It's kind of a wide range. Everybody kind of defines their own emergency.
Absolutely.
We certainly understand that it's a difficult thing for a lot of people to do. So, I mean, we certainly take all the calls very serious. Somebody calls, they understand it's an emergency line, that the emergency is extremely real to them at that point in time. Can be everything from information seeking. We get lots of calls from members of families or other people who are calling looking for information, who might have questions about concerns about people and friends or family members, and trying to get information about assessing their risk, trying to find information for help, trying to assess maybe what they need to do to get somebody some assistance.
So you'd have to just call for yourself. You can call for a family member, a friend, someone you care about.
Right, and we get calls from family members, neighbors, friends. We get calls from other healthcare providers, social service agencies who may have somebody they're working with and they're just looking for some support or some guidance or some supervision as far as, what next steps might be taken to assist somebody further.
What would next step possibly be if I was in crisis, I called the line, I was perhaps not, I perhaps didn't have something in my hand I was ready to act with, but I felt very close. What might potentially happen?
Well, we would talk on the phone as long as we felt that it was necessary until, the person was kind of comfortable that the situation was stable to kind of do a next plan. Options include having somebody meet with you immediately And in that case, we would have you during the day come to one of the West Central offices where one of our staff would sit down and meet with you. After hours, typically, we would have you go either to Valley Regional Emergency Room or the Dartmouth Emergency Room, where you would sit down and speak with one of the professional emergency staff.
I think sometimes people are reluctant to call these lines because they're afraid of, some sort of negative consequence that might happen. Are they going to call the police and are going to be people in my home at 2 o'clock in the morning because I'm having a rotten night? Is this going to affect my health care negatively? I know before the passage of the Affordable Care Act, people might be worried about losing insurance because of pre-existing conditions. Can you say a few words to reassure people on that point?
Yeah. Well, clearly, safety is the paramount concern, and obviously we do what we can to alleviate a situation. We're not looking to make a situation more difficult or more stressful, but at the same time, safety is the #1 concern. In 99% of all cases, we can help somebody come up with an effective plan and come up with a suitable disposition. On rare occasions where we're very concerned about somebody's safety or we're not feeling safe, then we certainly, will call the police and have the police do a well-being check. Certainly something that is not done
Lightly. Yeah, and I think that will be reassuring for people to hear. And I want to pull back the lens a little bit and talk about one of the reasons we're here today, which is some of those statistics on suicide in northern New England. It's a very serious problem in northern New England overall, in Vermont, and in New Hampshire. Suellen, do you want to talk a little about that?
Absolutely, absolutely. Unfortunately, the numbers are not decreasing. And there's one statistic that I think is really startling to people, and that the fly, and that really is the idea that more people commit suicide in the United States than die in motor vehicle accidents. Approximately 36,000 people a year die from suicide in the country, and about 32,000 people die of motor vehicle accidents. Unfortunately, the stigma of mental health and of suicide is alive and well. And so because of that, people don't talk about it. And so it doesn't seem as prevalent to people because families, unfortunately don't want to talk about it. I was talking to a newspaper reporter not too long ago, and he was saying that it's sort of the unspoken code that people don't print it.
It's not in an obituary the
same an obituary.
Way an accident would be reported and the obituary.
No, they say the unexpected death of somebody, if you look at the obituaries. And so, unfortunately, we need to really talk about it more so that people feel comfortable speaking about it, so that people are comfortable reaching out and getting treatment. And right now, people are afraid for all the reasons that you talked about. Whether it be employment or insurance or anything else. And so we really have to do things like we're doing right now, which is to really try to educate people and say this is an important crisis in our society and that we need to address it appropriately. So there are more suicides than motor vehicle accidents.
And much like motor vehicle accidents, you cannot predict by race or lifestyle or age who is at risk for suicide.
Absolutely not. It crosses all economic and social and any barriers that you would think, and I'm sure there are people out there that have preconceived ideas of people who commit suicide, but if you actually were to look at the demographics, the information about each of these people, you'd be very surprised that it does cross all socioeconomic groups.
And one thing that I used to hear growing up, and fortunately I'm not hearing much anymore, but I want to bring it up and address it, as I hear that suicide is a selfish act. And I wondered if you had anything to say about that.
Well, I mean, certainly there's lots of cliches, and cliches always have some evidence of truth to them. Another cliche that's sometimes said is that suicide is kind of the angriest thing that somebody can do, and that there are suicide survivors. They're called suicide survivors, and that for every successful suicide, there are 7 or 8 people who are significantly impacted for the rest of their life because of that death.
And our position on this is that people that commit suicide have a mental illness. These are not people that choose to leave their loved ones. These are not conscious choices where someone would sit down and say, you know, I think I'm going to kill myself and leave all my loved ones and all my family behind. And that's not, you know, from people that even have survived suicide, that's not how that works.
Yeah.
These are people that are mentally ill, as a general rule, and they're lost in whatever's happening in their life. And so it's not a conscious effort to hurt people or to leave people. It's an important distinction to make.
I actually had a friend who was very depressed who told me a couple of years later, when she was doing much better, that she was at that point thinking that her family would be so much better off without her, because that was how deep the illness had gotten into her.
Yep.
There are actually two, and only two factors that often will produce suicide thoughts in people. One is pain, extreme pain. It can be physical pain or emotional pain. And the other is no easy way out of their pain. And when people are sitting with their pain and their emotions and their distress for a long period of time, are trying the best that they can and things don't get better, then there's a part of their brain that starts thinking about ideas, and sometimes it doesn't think about the greatest ideas. And part of depression is isolation and not using your support systems. So actually what happens is that you start listening to your depression more than you did before, and if that's all you're listening to, it just becomes like quicksand. The more you fight it, the deeper in it you get. And so it's trying to help people understand that there are ways out of their distress, and that it's not going to be this way forever. But also validating the fact that right now that there is that degree of stress or distress in their life that produces these thoughts or ideas.
Hopelessness is a big factor. To Fred's point, is that the idea that nothing can change, and that people give up on the fact that there are alternatives out there. So hopelessness is a big issue when you're talking
or that
to
any
people.
change will only be something worse, like you said with the quicksand. That was a great way of looking at it, I think. You get about 3,000 calls a year.
Yes. Yes.
I know there's no typical call or a typical night, but can you tell us a little bit about what life is like on the front lines?
Well, it's always changing. It's not predictable. When you think you've heard lots of issues, there's always another one that seems to come up that you haven't encountered. A lot of the people who call, again, are people who may know of our services, may be involved in our services, and part of their treatment is needing some extra time or extra support to get through either a night or a weekend or a difficult time. And we'll call for skills coaching or sometimes questions about their medication. We have people who have been part of our system before who are calling, who are going through a difficult time and may need to just touch base briefly as far as talking about kind of what's going on or some refreshers to things that went on. And then there's calls from, again, the general population with questions and concerns about either themselves or family members or loved ones, trying to get information very quickly in situations that to them are emergency or crisis, and that they're needing to make some kind of response and wanting the best information they can in order to make good decisions.
And do you feel like you guys make a difference?
Definitely. It's very reassuring to have people come up to you and say, you may not remember me, but you were really helpful, and you got some help for my child, and they're really doing well, and those happen all the time, and they're just heartwarming.
That, I think, is the other side of the stigma, is that unfortunately some people are not able or willing or feel they can come forward and say, this happened to me, I got through it, there is hope. And so it's good to hear the other side of that people do get through it and they do improve.
Yes.
And I think, as you said earlier, from when you started 30 years ago running the line, there's been so many advances in treatment and in understanding of both the disease of depression and of the problem of suicide. I think that makes a big difference.
I met with a man who, in a local industry, who came up one day and said, do you remember, and he mentioned one of the staff that had worked for me in the past, and I said, yes, and I said she retired and she was doing well, and he smiled and said, well, she picked me up out of the gutter and she got me some help and she got me into treatment, and here I am, and I owe my life to her.
It's hard to beat that.
Right.
I think that's part of the kind of dark door that mental illness and depression have been in, and that people don't get to see people walking to the light. They don't get to see the happy end, the happy continuation of life that a lot of people have.
And part of reducing that stigma, too, is the idea, we often use actors and actresses and well-known people to talk about their illnesses or their family illnesses, because the public looks to these people for information, and they look to these people as role models. And so more and more people are coming forward and saying, you know what, my family member has this illness, or I have this illness. And so the more people are willing to talk about it, then the more people are willing to reach out and get help, because these are people that, firsthand experience saying, there is help for this, and we're people that have lived through this and improved.
Yeah.
But oftentimes people do reach out to those people because people value their opinions, and they also realize that it can happen to anybody.
Yeah. And it feels like there are more people out there who've been there, I
That's
think,
right.
is part of it.
That's right.
So if you have someone in your life, a friend, a family member you're concerned about, how do you support someone who's depressed who might be suicidal?
Well, I think it's kind of looking at a lot of the signs and symptoms and trying to identify people who maybe are at risk. And as I mentioned before, one of the issues that go along with suicide is depression. So it's often looking at depression or symptoms of depression. And there are many of them. Sometimes depression is one of those words that can mean both an illness, or it can be a mood. You can be depressed for a day, or you can have a major depression, which is an illness. But when you're talking about depression, you're talking about something that's been there for a period of time, a short period of time. We're just not talking about a bad day or two. But it starts affecting a wide range of our life. The symptoms of depression are a depressed mood, feeling lonely, feeling empty, feeling sad, feeling tearful. That is there most of the day, nearly every day. A loss of interest in activities or pleasure in activities. Things that used to be fun aren't fun anymore. Things that you used to enjoy doing just don't bring you the same pleasure or enjoyment, or you're not doing them as much as you were doing before. And of all the symptoms of depression, those are two of the most overwhelming, and the ones that we look at. There's a change often in people's sleep. It can be they have trouble falling asleep, which sometimes is more stress related, but often in depression people have what is called mid-cycle awakening, which means they fall asleep fine, but around 1 o'clock or 2 o'clock in the morning they're wide awake and maybe awake for many hours and can't get back to sleep. And when it's dark and quiet and you're thinking about your depression, those can be really very bad and very vulnerable times.
And again, that's the time when you're not going to pick up a phone and call a friend because you might wake them up.
Right.
Your normal sources of support may be unavailable.
Absolutely, absolutely. And again, in bad emotional states, the worst thing you can do is have it dark and quiet and just focus on your bad emotional state, because that's all that's influencing you at that point in time.
It becomes self-reinforcing.
Yeah. And then sometimes people have early morning awakening, which means that they would like to wake up at 6, but they're waking up each morning at 4 for reasons that they don't understand, and then are feeling tired and fatigued over the course of the day. Then there's changes in appetite. Sometimes it's more, sometimes it's less. Sometimes when people get depressed, they eat more than they do and gain weight. More likely, people have a loss of their appetite and aren't interested in eating, lose weight, can't stand being around food. Sometimes people say they don't even like to look at it or smell it when they become significantly depressed. There's changes in activity level. People sometimes get very restless, or sometimes they have psychomotor retardation, which means that they move slower and talk slower.
And again, this is caused by the mental illness.
It's caused by the mental illness. This is caused by the depressive symptoms. The brain chemistry, the serotonin levels in the brain that decrease when people become significantly depressed. There are signs of being worthless and hopeless and helpless. Problems with poor concentration, indecisiveness, not being able to make decisions. and then thoughts about death. Sometimes it's just thinking about dying. Sometimes it's thinking about death in general. Sometimes it becomes thinking about our own death, and then, thinking about our own mortality and whether or not we want to be alive, and then start thinking about, if we don't, how we might do that, or thinking about ideas or plans or means. And that becomes the real serious signs when people become suicidal.
And I remember reading somewhere, so please correct me if I'm wrong, but that starting to ideate, the really kind of picturing or thinking about the suicide, that is a really serious symptom.
Yeah.
That it's not necessarily, oh, I was just thinking about that. It's probably a sign that something's really wrong.
Right. And people think about everything in the world. So
oh, yeah,
certainly
of course.
They would think about that on occasion.
Yeah.
But when you find it recurrent, when you find it starting to become distressing, when it start becoming part of your life,
a little itch in your brain that never goes away.
Right. Then that's a sign that, hey, that this isn't okay. This isn't who I want to be. This isn't what I want to be doing. But I have this idea that's now becoming pervasive in my mind and affecting my life, and things ought to be going better, and what am I going to do about it?
So if you think a loved one, a friend, is very depressed, possibly suicidal, how should you support them?
One of the most important things, I think, or a couple of important factors, be a good listener. I think that people bring their own thoughts or ideas to the conversation, and really the best thing you can do for somebody is to be a good listener, hear what they're actually saying, and don't minimize it. And I think that's an important piece. Unfortunately, many people still believe that a lot of the behaviors that Fred just talked about, they have control over. And so they say things like, come on, just get out of bed and get moving. Come on, just get up and, and have breakfast. And it's as if the person has a choice, and that in fact they're just choosing not to do that. So I think part of it is don't minimize the symptoms. And if you really have a bad feeling about somebody, or that you're really concerned about them, then reach out and talk to professionals. Don't let that bad feeling sort of ruminate in your own mind, but you're afraid to act on it. Mm-hmm. So do something about it if you're really concerned about the person. But those are really important factors to somebody who may be trying to reach out to you, but if you minimize it, they're going to retreat and not really continue to reach out.
What about someone who you're worried may not be responsive to professional support if you say, I think you need to talk to somebody? If you call the line, will you get some advice on dealing with that issue and supporting that person?
Yeah, again, nobody likes somebody to kind of point their finger at them and say, there's something wrong with you and you better go do something about it. But I think people can acknowledge the fact that things ought to be going better than they're going, and I think people can acknowledge that they're working as hard as they can, and those are really two critical assumptions when you work with people, that things can change, and that it's silly to tell you to go and try to do something harder because we believe you're trying as hard as you can. Right now what we need to do is think about trying to do things different, not the same. Mm-hmm. So going back and just trying harder is not an effective intervention. It's time to try to do things differently. So let's talk about what might be different, and maybe if we can't think about things that might be different, well then let's go and talk to somebody else and about ideas about how things might be different, and then that becomes the brainstorming about treatment and treatment options and things like that.
And for teenagers, it's important if you're concerned about a friend. Yes, you want bring the person to an adult. Talk to the person about going to an adult. Because the work that we do is not just talking to your friend. The work that we do is medical intervention. These are treatments that are, as Fred said before, best practices. They're medically modeled treatments, and so it's not the equivalent of talking to your best friend when you actually need professional help. And so make sure that you encourage the person or bring to the attention of an adult if you're very concerned about a friend.
There's a model that we'll often use that people understand and can relate to, and that is kind of using depression and suicide as an analogy with pneumonia. and that sometimes, nobody wants it, but they get it anyway. If it doesn't get treated, it's likely to get worse. People can end up in the hospital because of pneumonia. They can end up in the hospital because of depression, and that they can die because of pneumonia and depression. And sometimes when they see that it isn't a willpower thing, but it is an illness that is treatable, that often takes the stigma away.
And again, the emergency health number is 1-800-564-2578. If you are outside the area and are listening to this, or you have a friend you want to refer, the National Suicide Hotline is 800-273-TALK. And thank you both again for being here today.
Thank you.
Thank you.